Greeting from Vietnam. It is such an honor to be invited here to share about my experiences about the current practice on mammography in breast cancer screening, diagnosis, and intervention in Vietnam. First and foremost, I want to talk about the current landscape of breast cancer in Vietnam. According to a study conducted by Globocon in 2020, number of new cases in female related to breast cancer in Vietnam for 2020 is the highest, accounting for 25.8% of new cases. The age standardized incidence and mortality of breast cancer in female are top 1 and top 3 accordingly. Patients getting diagnosed with breast cancer in Vietnam are getting younger and the cases are getting more complex as well. Mammography is the first-line breast cancer screening method recognized by FDA for reducing mortality rate of breast cancer. Through a generation of mammography units from analog to CR, then to DR without films, but with many advantages: faster image acquisition, better quality images, high volume capacity, and greater dose efficiency. In recent years, tomosynthesis and contrast mammogram machines have provided more details about the lesion, avoid missing out the lesion, and evaluate the enhancement of lesion to overcome the overlap of dense breast tissue. Let's take a look at the clinical case I come across recently. She's female, age 55 years old. She have no symptom. Went for screening. She have no family history of breast cancer. With a clinical examination and blood test result is normal. The patient was indicated for breast ultrasound and there was no abnormality seen. But on mammogram, we can spot some microcalcification with linear morphology close to the left nipple. In the lower middle quadrant, there is linear amorphous, coarse, heterogeneous calcification, segmental distribution on magnification view. On MRI, in the middle half of the left breast, there is a mass with irregular border, hyperintensity on T2, ring-shaped increased density with limited diffusion. On contrast enhancement of MRI, the lesion appears small inside and enhanced, and are clearly visible on subtraction sequence. A satisfactory biopsy sample must show the microcalcification, and the final histopathology was DCIS. It is one of the early diagnosed cases and successfully intervened under the guidance of mammogram. In Vietnam, mammography is indicated for screening of healthy population for women aged 14, 15, and above. Screening for population with high risk factors such as BRCA1, BRCA2 gene mutation, patients have family history of breast cancer, or received radiation dose for the threshold age 10 to 30. With screening, similar to other regions of the world, we use to position their MLO and CC view. Besides screening, mammography can be used for follow-up after treatment or when the patient is diagnosed with benign tumor, nipple discharge, change in skin color, etc. Mammography is used to check when there is palpable lump in the breast tissue or to support when other methods such as ultrasound or MRI detect the suspicion of lesions. In the case of gynecomastia, mammography is also used for diagnosis. Finally, mammography in Vietnam is used to develop guidelines for breast intervention. Tomosynthesis is getting more focused and widely practiced in Vietnam, though there are not many facilities with this equipment available. We do hope to have more in future. We use tomosynthesis combining with 2D mammogram to screen a breast cancer or to diagnose when the patient have abnormal symptoms detectable on 2D ultrasound and MRI. Using tomosynthesis in intervention will help carry out procedure quickly and accurately. Tomosynthesis overcomes the limitation of overlapping in 2D mammography, thereby increase the detection rate of small invasive breast cancer up by to 94%. This is done by capturing images in an art and reconstruct to create 3D image. You can understand the advantage of tomosynthesis with the illustration. On the left, you can see the 3D mammogram of the rows have overlapping petals, high important details, while the tomosynthesis image on the right reveals important detail of the object. We use BIRAS system for standard report, classification of the lesion, and management. With this image, you can see that despite breast density is type A almost entirely fatty, it is very difficult to detect in 2D. Lesion can be observed clearly on 3D image. 3D synthesized image integrate from image from DBT can reveal the structure of the breast tissue similar to the 2D film. Tomosynthesis is so to increase cancer detection rate when used in screening, decrease the false positive rate, and increase the positive predict value for recurrence, according to the one article in 2015. Contrast about angiomammography, to be honest, we have knowledge about it, but only few facilities in Vietnam practice this technique. Thus, we don't have much practical experience with this technique. With the advantage of helping to better diagnose lesions as well as supporting post-treatment diagnosis and follow-up. CSM can reflect MRI when needed and save time and money. In the future, we hope this technique will be available in Vietnam more and more. The sensitivity of CSM is similar to that of MRI and also show its advantage in dense breast. On the pre-injection of image, the lesions are superimposed and difficult to recognize. But with CSM image, the lesions are clearly shown in both positions. Images after treatment monitoring shows a small enhanced lesion after injection. It's corresponding to the lesions detected on ultrasound and MRI. Regarding the screening guideline in Vietnam, in fact, we still do not have a national breast cancer screening guideline. Each facility applies different globally reputable guidelines. For example, the U.S. Preventive Service Task Force screened every 2 years and starting at age 50. They not recommend for breast cell examination. Why the Japanese guideline to start at 40 and do some screening annually. As a matter of fact, Vietnamese women have dense breasts, so mammography has always been the standard for screening, but is misdiagnosis 50% women with dense breast tissue, a sensitivity close to 48%, This leads to an increase in concentration in the fields. Dense breast tissue need more screening support, such as ultrasound or MRI. We try to follow FDA recommendation to deliver a quality mammography to help patients get accurate screening to identify breast health problems early. In Vietnam, medical facilities encourage to combine ultrasound 2D, 3D, and mammography 2D, 3D with monthly breast cell examination. However, we still have many issues that need to be resolved. We need the specialized training program for breast clinicians, oncologists, radiologists, and pathologists, the three diagnoses essentials for early breast cancer detection. And the second issue is whether to require mammography as the first tool for breast screening. The pros and cons of screening and detecting breast cancer at early stage must to understand by every level, from management, executive to general practitioner. Also, we need establishing an association of breast cancer to give out official and professional recommendation for breast screening guidelines. We also need more support from government requests to get a guideline in the breast cancer screening and increase the awareness for the public to get more support, and cooperation is very important. So in Vietnam, the patient is concerned about the pain, the expense paid for the breast mammography, the quality of the equipment and the skills of the technicians and radiologists are not guaranteed everywhere. Compliance with the screening and treatment protocol is not high. Thus, the rate of early detection of breast cancer still remains low. I want to emphasize again that currently there is not yet a breast cancer screening guideline on a national level. Equipment for mammography is not standardized nor adequate in medical facilities. According to number by mammogram units provided, the rate of using CI is still high, up to 2/3, results in reduction in image storage capacity, low image quality, and risk of overexposure. However, we have had improvement in early breast cancer detection compared to 10 years ago. Up to 30% patients went to the hospital and got diagnosed with breast cancer stage 3 and 4. However, recently, study shows that this rate has dropped to 55%. About mammography in intervention, the objective is collecting samples for diagnosis lesion by 4 and 5, observable on mammography, for example, microcalcification, architectural distortion, or non-mass neoplasm. We use the technique of breast localization while biopsy needle, core biopsy needle, and large size biopsy needle 10 goes and 11 goes with vacuum suction support VIBB. We also use some localization Y like hook Y, JY, or double JY. There are no absolute contraindication for this technique, but it should be noted in some cases as follows: severe systemic disease, inflammation in the breast area, non-stop bleeding, or allergy to anesthetic. According to the result of screening, more and more small lesions were detected, and the need to determine accurate position of the lesion helps surgeons to perform better. This technique requires lesions that needs to be clearly seen in two positions to be identified in space. It is possible to use the routine manual technique or use a whole grid or alphanumeric grid or under the stereostatic and tomosynthesis guiding. There are some complications of that technique: pain, bleeding, vasovagal reflex, allergy to the local anesthesia, the chest wound injury, moving of localization wide, or infection. For manual localization, we will measure the distance from the lesion to the nipple, from the lesion to the skin surface, and from the lesion to the chest wall to locate the lesion accurately. We can also use a whole grid or an alphanumeric grid to help locate the position of the lesion. This is the female patient, 67 years old. Upon screening, we detect a linear calcification near the left nipple, and on MRI, it is enhanced. We proceed to position the Y needle using an alphanumeric grid. The WJY is positioned correctly at the lesion. The surgeon did not get the lesion in the first time, but managed to get the tiny calcification on second try. On the sample prepared by pathologists, we saw a clear microcalcification, and the final histopathological result was ductal carcinoma in situ. With the next patient, we detect architectural distortion. With JY, we locate the lesion accurately. Then in the sample, we find the lesion, and the final result is invasive lobular carcinoma. The next patient is 35 years old female with architectural distortion in the left breast, undetectable in ultrasound, and on MRI, we can see non-mass enhancement lesion. Using WJY, we obtain the lesion, and the final result is the atypical ductal hyperplasia. The 3D spatial localization technique is used more and more recent due to its speed and accuracy. The accuracy is similar to use the whole grid or alphanumeric grid. When the lesion is located, we will perform to insert the Y needle. The lesion have to see on both a pair view, and after that, we will take the CC and ML 90-degree view to locate the exact position. We have to pay attention as the breast is pressed when locating the lesion. If the Y needle insertion divided by even a few millimeters, when released, it can deviate even more than 1 centimeter. To minimize needle movement upward, the tip is often inserted deeper, compensate for tissue elasticity, and will get the needle in decided position when breath is released. This method is commonly used for biopsy. This is the female patient with 62 years old, diagnosis with breast cancer on the left breast. However, there are clusters of microcalcification by fall in the left breast. Using stereostatic lesion in the center of skull view and can see also in the pair view. We were able to bring the localization needle close to the nipple. This picture shows that the hook Y tip is very close to the microcalcification. After surgery, the sample was scanned. Results show that the sample has the lesion with microcalcification, and the final result was ductal hyperplasia. We have also conducted and implemented stereostatic biopsy in a number of facilities, but not widely. Patients are prepared in both sitting position then to correct movement as well as reduce anxiety of the patient. We also prepare and perform the procedure in lying position. The patient is more comfortable lying down. Benches allowing the patient to lie on their side can reduce the mentioned disadvantage and especially necessary for VIBB. We use 14, 10, and 11 gauge needle, perform the procedure, scan specimen, place markers, and compress if using VIBB. We have to pay attention with some lesion too close to the chest wall muscle, chest wall near the nipple or on the small breast. Similar to localization technique, lesion must be seen on skull view and pear view. If the lesion is too close to the left or right of the skull view, maybe it will not detectable at the pear view, so we cannot calculate the location of the lesion. We have to be careful. If we cannot identify the lesion on two views, we have to through the different position or even train the method. We do local anesthesia along the part of the needle with 11 gauge needles. We use take from 14 and 18 to 24 course. After the needle is drawn, we will take a scan to evaluate the remaining tissue in the breast. The sample will be scanned to assess whether or not enough lesions have been obtained. After the procedure is over, we will retake it to assess the lesion that has been removed, and the marker will be placed in the correct position. We have to compress breast, bend, and instruct the patient how to avoid bleeding. If multiple lesions are removed, label carefully because VIBB needs a lot of anesthesia. There is the female patient. She was born in 1957 with detected microcalcification by 4 in the left breast during screening. Lesions can be observed on skull view and pear view also. The biopsy needle was directly inserted into the cluster of microcalcification. After shooting, the needle through was in the correct position of the microcalcification. The marker was also inserted into the position where the microcalcification was removed before. This will support for follow-up after treatment. Scanning of both sample taken immediately after the procedure and the sample prepared by the pathologist showed observed microcalcification, and the final pathology result was ductal carcinoma in situ. The next patient is the female patient, 48 years old. Screening detected calcification in the right breast in category 4, and it is enhanced on MRI. Using tomosynthesis to locate the lesions accurately and perform biopsy to extract microcalcification, and the final result is ductal carcinoma in situ. In conclusion, mammography in Vietnam is used in screening, diagnosis, and intervention, though has not achieved maximum efficiency, but the landscape is gradually improving, with technicians and radiologists getting trained well, and the technology is enabling the machine to work even better. Intervention guided by mammography from simple to complicated procedures are increasingly applied and plays an important role in early detection of breast cancer. Knowledge about indication, contraindication, complication, and cooperation among specialists is very important in determining the success of technique. There is a need to establish a national guideline for breast cancer screening in Vietnam. Medical facilities should follow the guideline with adequate technology and qualified professionals. This will improve overall early diagnosis of breast cancer and lower mortality rate in Vietnam. March is the month of International Women's Day. I really wish that our beautiful women to take care of themselves, prevent from breast cancer by using the screening methods such as the mammography and ultrasound. Thank you for your attention.